Good morning, everyone. We're going to go ahead and get started. We wanted to leave a few minutes for everyone to join the call. My name is Dr. Naina Harawa. I'm a professor at the David Geffen School of Medicine at UCLA and at the College of Medicine at Charles R. Drew University of Medicine and Science. I'm here in the role of Director for the Policy Core for the Center for HIV Identification, Prevention, and Treatment Services at UCLA, also known as CHIPS. And we're talking today about the important issue of gaining patients' trust in the age of COVID-19. This is actually the first in a series of the second in a series of trainings that we have been doing as a part of CHIPS to address issues of medical mistrust and how they affect engagement in both HIV care and services, but also care for STIs, hepatitis, and many other conditions that affect individuals and that also tend to affect racial and ethnic minority individuals at higher rates. We are very glad to have so many of you joining us here. We have over 200 people registered for this event and at least 170 people joining us today. For those of you who are interested in learning more about CHIPS, you can welcome to go to our website. I believe it's ucla.chips.edu, CHIPTS. And there you will find information both about our center and about the conference that we did on medical mistrust last year, including some videos for that conference and some references that are very useful on the subject of medical mistrust. In addition, you will find detailed bios for the people who are joining us today. So that's a little bit about me. Just to give you a brief overview of our agenda for today, we are going to have a number of panelists who are going to introduce themselves and give brief presentations, and then we will have a panel discussion among those individuals moderated by Dr. Abida Mani, and then we'll have time for questions and answers from the audience. Throughout today, you are welcome to share questions. Please just write your questions in the Q&A box within Zoom. You should find it at the bottom of your Zoom. And we will either address your questions directly in the Q&A or we will give them to the moderator to discuss at the last portion of our agenda. If you do have something that's very confusing and that you need clarifying, I will interrupt Dr. Amani so that we can get that clarified right away. I think those are the primary detailed things that I need to cover. I'm sure Dr. Mani will catch anything that I might have missed, but I'm very proud to introduce her and the other panelists. Dr. Mani is a colleague of mine for probably close to 20 years now. She's an associate professor at Charles R. Drew University Department of Urban Public Health. She's also the co-chair of the COVID-19 Task Force on Racism and Equity, which is part of the CDU UCLA Center for the Study of Racism, Social Justice, and Health. And one of the many things that I appreciate about Dr. Amani is that she brings an incredible critical perspective and critical lens to the work of public health and the work that so many of us do, both in public health, community engagement, and medical care. And she's going to be moderating our panel discussion today. Dr. Amani.
Thank you, Dr. Harawa, for that wonderful introduction and the invitation from the team to be able to moderate this really timely event. As we can tell from the participation, there's a lot of information that we hope to gain here that we're all very eager to get into. It is both a continuation of things that we have been committed to and concerned about, and extending now into areas that we theoretically knew would be here in other places of the world. We knew that these were issues that folks were dealing with, and now here in the United States, these are pressing times where a lot of these things are coming to a head. And so I thank you guys for having kind of the brilliance to organize this event, and I really appreciate being asked to join. Without much further ado, I would love to create, for the panelists to be able to introduce themselves, to kind of share their brief remarks. and to give us a sense of how they connect to the topic that we are discussing today. Mr. John Forbes will lead us off. He is the Program Director for the HIV Counseling and Testing Program at Charles R. Drew University of Medicine and Science, the Oasis Clinic storefront.
Good morning, everyone. Thank you for having me here. I'm here just to share a brief overview to discuss the challenges that we have in our community addressing HIV services, PEP and PrEP in South Los Angeles. We have noticed a significant decrease in testing, PEP and PrEP services. I work directly in South LA, which is primarily Black and Latino populations. And we know that both populations do have medical mistrust due to culture. Myself, I'm Black Latino, and in my experience, I have seen how Latinos adhere to home remedies and medical care, or seeking medical will be the last resort. You kind of trained to go by family trends, friends might tell. And in the Afro-American community, my experience has seen a lack of education and resources in the community, which leads to medical mistrust. Thank you.
Thank you for that introduction, Mr. Forbes, and we look forward to discussing more with you later on. Next, Ms. Aziza Lucas-Wright, who is the Academic Community Liaison for UCLA Clinical and Translational Science Institute, CTSI, at RAND and Charles R. Drew University of Medicine and Science. And that is just one of her many roles. I would love to give her an opportunity to introduce herself and to give her introductions.
Shall I share my screen now, or is that a little later?
I believe that this is a great time for you to share your introductory remarks, yes.
Wonderful, thank you so much. Okay, very well. So let me then. Next slide. Let's see if I can get this. There we go. Okay, there we go. Wonderful. So I wanted to just direct your attention, well, by way of introduction, my name is Aziza Lucas-Wright, and I am community faculty at Charles Drew University of Medicine and Science, co-chair of the Division of Community Engagement there. I'm also the executive director of South Central Prevention Coalition, a not-for-profit in LA that addresses the social determinants of health from a primary prevention perspective relative to strategies. I also do a considerable amount of work in the faith community because I'm an insider. My husband was a pastor that was not only concerned with the spiritual aspects, but a very strong pastor that was community involved relative to social and restorative justice. So I want to go direct your attention to the top of the bar that has sort of this little quilt, this little small quilt of logos. I want to direct your attention though to the third quilt, I'm sorry, to the third logo. And it says the Partnership for Equity and Equality in Health and Wellness. And I want to just take a look at that optic just for a moment, just to introduce that, because that has a lot to do with sort of some of my work. This particular logo was a part of the thinking of a large number of community and academics. When the brainchild of Dr. Loretta Ford Jones, who's gone on to ancestorship as of November 22nd, 2018, when Loretta Jones first had that brainchild, shared it with Dr. Keith Norris, and we then began to, and Dr. Norris, by the way, enabled, in terms of resources, enabled us to begin to plan and share and come up with this very novel and very wonderful community faculty track at Charles Drew University of Medicine and Science. And that is our logo. And it shows that academic work, the work of academic, the work of community are mutually embedded. And there's a direct pathway on the castle that that it is bi-directional. There's a going in and there's a coming out, that we are mutually embedded. All right. So today we're going to be talking about trust. I'm going to be talking about trust from a community partnered and a community perspective. And so the dictionary says that trust is a firm belief in the reliability, the truth, and the ability or capacity or strength of someone or something. But trust is built on the relationships that we have. Now, distrust, and this is a reason why we're sort of parked here, is a lack of trust or confidence. And that's generally based upon not only some personal experiences, but it's also based upon what people tell you about a people. And African Americans, we have a lot of experiences that we can hearken to relative to distrust of this country. However, those who provide services and who we have to have have to rely on for certain kinds of things, a lot of that distrust comes from how we've been portrayed in media and how we are viewed. And so that is a strong disconnect. Relative to the historical backdrop, this particular article in April of 20 said that roughly 40 million African Americans are deciding minute by minute, and I say milliminute by milliminute, whether to put their faith in the government and in the medical field during this particular time. And we certainly have plenty of reason to. Many of you have already heard about the Tuskegee effect. I doubt that you know about the radiation trial done with African American boys that was egregious. And then another one that we can hearken to is the easy measles trials in Los Angeles, in Haiti, and in Africa. Just a few of the varying degrees of no goodness relative to clinical trials. So just to park a bit here at the easy measles trials. So this was done with Los Angeles children, African American children in Los Angeles. And Dr. David Satcher at that time, who was with the CDC at that time, says that he was actually shocked by it and that it was a big mistake. Now, what was indicated was that none of the children in Los Angeles, now of whom were 5 years old back in 96, was injured by the unlicensed vaccine. However, similar trials conducted in Africa and Haiti with the vaccine raised questions about its relationship to an increased death rate among female infants who received the more potent of the two dosages being studied. Those children died within 2 years. In light of the questions, the LA study was halted in 91. And Dr. Satcher said this, every little mistake like that seeds the concerns of people. We need to move to a new level of assurance so people can really trust what we're doing. And so when I hear, just yesterday evening, we were on a call talking about the vaccine, and folk were sort of talking about how Black people don't participate, as if Black people are the problem. If there's an inherent issue or problem with Black people not wanting to participate, well, there are reasons. Mistrust is founded upon breach of trust. And so these are some of the that you can read. I just note those there, and that's it. Okay, so we'll talk later.
Thank you, Mrs. Ziza, and I'm sure we'll coordinate with the team to figure out a way to get those resources to the attendees. I really appreciate the way that you have started this conversation in the historical context, both getting us to be critical about some of the root causes of mistrust and connecting it to larger systemic issues of anti-Black racism. So thank you, Mrs. Ziza.
Thank you, Bida.
Next, Solange Madriz. She comes to us from UCSF as an academic coordinator for the Global Health Sciences. Welcome, Solange.
Thank you. Hello, everyone. My name is Solange Madriz, and I work as an academic coordinator before COVID-19 I used to work on maternal and newborn health, on prevention of maternal and newborn deaths. And for the past 4 or 5 months, I've been working as a contact tracer, first for the county of San Francisco, and over the past months, I've conducted over 100 contact tracing calls. Contact tracing is one of the pillars that the state of California is using, one of the key interventions that is using to stop the spread of COVID-19. And I would like to talk to you about what it is. Contact tracing is communicating with persons who may have been exposed to an illness to, one, notify them of their exposure. Second is to support the quarantine period. Third, recommend strategies to reduce further transmission. And the main goal of all this is to improve community and population health. The idea is that by notifying early to people that they may develop symptoms, is that they will change their behavior. And so the aspiration is that they will stay at home to prevent from getting others from getting sick. You may be wondering, what do you do during a contact tracing call? And well, we ask a lot of questions to our contacts. Some of the questions that we ask are demographic. Other ones are related to if they already have symptoms. We ask them about their living situation, the number of people living with them, also the characteristics of their household, the number of bedrooms, the number of bathrooms, to assess the likelihood that they will be able to quarantine properly. And lastly, we also ask about any underlying medical conditions that they may have. The idea is that with this, we classify them as a high risk, medium, or low risk category. So during a contact tracing, we ask a lot of questions. Some of them are very invasive, and so this is very good and appropriate following Dr. Aziza's comments about the trust. And the trust that the contact tracing can build in a matter of seconds, it's very important, because that is connected also to the likelihood of the success of the call. What information contact tracers provide? So in addition of asking questions, we also provide recommendations, and we also provide some information. So some of the things that we talk about are recommendations on how to quarantine. We assess if the person can quarantine safely in their own household. And in the county of San Francisco, if the person cannot quarantine at home because if it's a crowded household, we refer them to a quarantine hotel. We also make referrals for other social services that may assist the family, the contact and their family during the period of quarantine. And lastly, we follow up with communications to assess for symptoms and well-being throughout the 14 days of the quarantine period. Some of the most common scenarios that I've encountered as a contact tracer and are categorized in these 4 ways is that a lot of individuals that I've contacted require a lot of social needs. They are experiencing food or housing insecurity. They do not have space to safely isolate or quarantine. They fear job insecurity if they comply with the suggestion of quarantine, that they will lose their jobs. And they also fear about their lack of access to healthcare. Some of them also have some barriers to safely quarantine because of their responsibilities to others. Some of them are taking care of children or elders. At the same time, some of the barriers to conduct this work is the context in which there's mistrust, there's stigma, and there are either values that some of them I've talked to. They think that it's better to get sick once and for all and then to be over with this. And lastly is everything that is connected to other, that we put in the other category, that is also important barriers for this work, is that some of our contacts are experiencing violence, depression, anxiety, and they fear for their immigration status and even their own beliefs in order to quarantine. And now, I would like to ask you for the next 30 seconds, if Nicholas, can you open the chat? And I would like to ask the audience. I've just described to you what it is, the questions that I ask and the information that I as a contact tracer provide. I would like to ask you to share with me in the chat. Nicholas, if you can open the chat and share with me, how would you feel if you get a call from me to tell you that you've been exposed to somebody with COVID-19? Can you please share with me your feelings or anything that will be going through your mind? Or in the case that you've already had this call, how would you feel? I see here, I will be afraid, I will be nervous, scared, anxious, scared, nervous. Cynthia says scared. Priscilla worried. I would feel this is an hoax. Fearful. I'll feel worried and feel responsible. Is this a scam? So I'd like to see all of these feelings and sentiments that the audience is expressing, because those are exactly the same things that the people who I'm calling are experiencing. And the importance of trust, and how trust you can build or destroy in the first, I would say, 10 seconds of the call. Now, I'd like to also to distinguish what case investigation and contact tracing is, because this is often a misconception of what it is. Contact tracing is done with close contacts, with individuals who haven't had a positive test of COVID-19. These close contacts are obtained, or we get the names and the phone numbers of these individuals through the case. And the case is the person with the COVID-19. So the case investigators are the ones who conduct a case investigation interview. They talk to a person with a positive test result, and because this is we're in a pandemic, all the people who are tested positive, the counties or the health departments of every county are getting a notification, and the health departments across the country are getting in touch with them. It's a reportable disease, so all of them the health departments are getting in touch with them. So the case investigator talks to the cases, and the case investigator does something called the contact elicitation, in which through an interview, they ask who could have been exposed to the person. And so the contact tracer is then the one who follows up with that. So this, the case investigators the contact tracers are distinct works, but they work together, and they work with the same goal in mind, to prevent other people from getting sick. I'd like to encourage you to ask a lot of questions, either in the chat or at the end of our presentation. I look forward to this discussion.
Thank you, Solange. It was great to see that you started to introduce the conversation of trust and resources. I want to let the attendees know that when we get to the panel discussion, it's also going to be solution oriented. So we'll be asking direct questions around how we can overcome some of the barriers that we are seeing. It also was great to see in the chat that people were both expressing how they felt for themselves, as well as those around them, whether it was for their patients and clients and what that meant for their own emotions, or being concerned, for example, the comment about being concerned about disclosing contacts because of issues of immigration status. So that's great. It's wonderful to see that the participants are here with us. Okay, our last panelist is Dr. David Goodman Mezza, and he is a assistant professor with the Division of Infectious Disease from the David Geffen School of Medicine at UCLA. He is an internist and an infectious disease specialist. Welcome.
Thank you, Bita, and thank you to the organizers for this invitation. I'm really happy to see so many friendly names as I scrolled through the participant list, and really there's probably many others that I would love to meet. I have the boring task of talking about the scientific data related to COVID and HIV, but I think it's really important as it'll really set up our discussion a little bit after. So really, HIV has been an example of what science, activism, and community can achieve. Really, before the introduction of combination antiretroviral therapy in 1996, almost 50,000 people died in the US due to AIDS. After the introduction of antiretroviral therapy, there was a sharp decline, and most recently, in 2019, there was only close to 6,000 AIDS-related deaths. In reality, these are 6,000 deaths too many. With our current interventions, there really should be 0 AIDS-related deaths. But if it wasn't for science, we wouldn't have never gotten to antiretroviral therapy. But on the other side, if it wasn't for activism and community, it would have taken us so many more years to get effective therapy. We've also had a dramatic decrease in new HIV infections, one through the introduction of prevention practices like condoms and needle exchange, but also through treatment for those who are living with HIV, and most recently through the introduction of PrEP for those who are at high risk for acquiring HIV. However, still in 2018, there were over 37,000 new cases, and really 37,000 cases too many with the interventions we currently have. Worldwide, there has been a dramatic decrease in deaths, although this has lagged considerably compared to HIV in the US. Here again, in 2018, there were close to 8,000 deaths too many, and we need to further our efforts so nobody dies from AIDS, and nobody who dies after living with HIV, anybody who is living with HIV should really die of old age. Now we're living in 2020, and this has been quite a year, especially with this unexpected pandemic of COVID-19 coming along. In less than 6 months, the virus has already led to over 150,000 deaths in the United States, and that's triple that of the deaths related to AIDS at its peak in 1996. So many questions have come up related to this. Given these parallel epidemics, what are the risks of COVID, getting it, having a worse outcome in people living with HIV? Many others, is COVID-19 more lethal since people living with HIV have impaired immune systems? Or is it milder since some of the damage in severe cases is really related to a strong immune response? Is COVID-19 similar in people living with HIV since antiretroviral therapy is so effective? Is it the HIV, or is it the racial structural disparities or comorbid conditions that also afflict people living with HIV that may be leading to worse outcomes? Or maybe people with HIV are protected as they are already taking antiretroviral medications, some of which may have activity against SARS-CoV-2. We know now from several studies coming from all over the world that there are many risk factors for severe COVID-19 disease, including older age, male sex gender, diabetes, cardiac disease, chronic respiratory diseases, being overweight or obese, having an organ transplant, and the different immunosuppressive drugs people on organ transplants are having to take. But is HIV a risk factor for severe COVID disease? And really, multiple large hospital-based studies from different locations in the US and abroad haven't really found this association of severe COVID and HIV. All of these studies are of all patients with COVID, and of course are biased because a lot of our patients living with HIV, since they heard COVID and since they heard that this is a pandemic, many of my patients called me and were very concerned, and by no means were they leaving their houses, right? So there may be some social distancing that our patients may be doing more than the general population, leading to less infections and less hospitalizations. However, a few studies have come out now specifically looking at HIV and COVID. This was one of the first. This was related to HIV and COVID in Spain. And this study described the incidence and severity of COVID-19 among close to 80,000 HIV positive patients who are receiving antiretroviral therapy in Spain. Of close to 80,000 patients, only 236 patients were diagnosed with COVID-19. And interestingly, patients receiving TDF, so tenofovir, based antiretroviral therapy had a lower incidence of COVID-19 in general, and no patient on TDF was actually admitted to the ICU. I wouldn't say go out and take TDF. This is more of a hypothesis generating statement than proof that TDF reduces the risk of COVID-19 or that of severe COVID. This was another study, now a US-based study. This is coming from Mount Sinai, where they compared people living with HIV, comparing those to people living without HIV, and really found no differences in death, no differences in intensive care unit admissions, no differences in mechanical ventilation, and in general, other adverse outcomes from COVID. Really, and their survival, the survival of people living with HIV was really similar to that of people not living with HIV. There's only one study, to my knowledge, that has showed an increased risk of COVID in patients living with HIV, and this comes from the Western Cape in South Africa, which showed the kind of the common risk factors that we've already talked about: male gender being at higher risk, older age, diabetes, other chronic diseases like kidney disease or hypertension, having tuberculosis. But they also interestingly found that people living with HIV were close to 2 times at higher risk than those patients living without HIV. Of course, populations living with HIV in South Africa are very different from those living in the United States and elsewhere due to the access to antiretroviral therapy, but this I find very interesting. This is one study that came out really early in the pandemic that really found no difference in taking an antiretroviral drug, lopinavir/ritonavir, for COVID-19. This was done in China in a randomized controlled trial. So really no effect of this drug in benefiting people with COVID. However, even though there might not be a substantial increase in the risk of COVID or the risk of severe outcomes, COVID has really impacted our ability to provide those pillars that we've been able to establish to prevent people from getting HIV or to treat people living with HIV or other conditions like STIs or harm reduction scenarios for people who inject drugs. We published this paper in AIDS and Behavior early in the COVID pandemic, and really the stay-at-home orders really led to decreased access in HIV testing and counseling and STI testing, really led to increased difficulties in managing HIV. A lot of our patients with fear of coming to clinics for routine appointments. However, telemedicine has really come to the forefront and has been an old important tool that we're actually now using. But then there's also been difficulties in patients accessing medications or getting tested, getting their viral load tests. And then for people for people who inject drugs, really an inability to access harm reduction facilities and medications for opiate use disorders due to limited hours at syringe services programs. And many sources have now indicated increases in overdose deaths. A large survey in people, in men who have sex with men and people living with HIV really documented some of these challenges, like decreases in quality of life, increases in anxiety, decreases in connections to family and friends, increases in difficulty in buying food or losing their job, or decreases in their work hours. Really, there's been a decrease in the number of sexual partners and those opportunities to have sex. However, there's been a marked increase in alcohol consumption. And as I mentioned before, decreases in STI testing and HIV testing. And for our people living with HIV, of course, almost a quarter or a fifth have reported decreases in getting HIV tests, getting HIV care visits, having trouble keeping their appointments, getting their labs, and although a very slight issues with access to HIV medications or taking their medications daily. And then lastly, I'll just present data of these overlapping epidemics. On the left of your screen in green, you'll see a map of LA County and that have the highest burdens of lack of HIV viral suppression. And really this is concentrated in this south central area of Los Angeles County. And if you look on your right, the map of the highest proportion of COVID cases, they really overlap in a similar fashion. And if you would plot the different highways, you can really see a triangle forming between the 5, the 110, and the 105, where we see the highest proportion of cases. So this is really concerning, of course, and because it, of course, overlaps with our patients who are at highest risk for viral non-suppression. So just in conclusion, really the COVID-19 pandemic has impacted all of our lives. But the risk of COVID-19, either getting it or having severe disease, doesn't seem to be much higher in people living with HIV compared to that of the general population. However, the mitigation strategies to curb the COVID-19 epidemic has really presented several challenges to people living with HIV and those at risk for HIV, and our ability to provide care and services for these individuals. And then lastly, of course, there is an overlap of highly burdened areas of HIV and COVID-19, and we are to see what will this translate into people's lives here in LA County. Thank you.
Thank you, Dr. Goodman Mezza, for that presentation. And now I would love it if we can have a conversation, getting more into the intersections of testing, treatment, as well as some of the structural racism that I believe we are both implicitly and explicitly talking about across the panel. So first up, and this is for everyone, we would love to know more. While you briefly mentioned how the COVID-19 pandemic is affecting provision of clinical care, could we go into more detail around the changes, the challenges, and the experiences? This is not only related to provision of clinical care, but as well as testing and prevention services.
Yes, John Forbes. I'd like to kind of piggyback on Dr. Goodman. Here in Oasis Clinic, we have one of the highest positivity rates in LA County, which is 4.2, compared to the LA County of 1.5. It's interesting because we service approximately 800 patients, and we have identified 15 patients COVID positive this year, and they all have recovered very, very well. And since March, we have noticed a severe impact. Usually on the average, we test approximately 100 patients. And since March, we have tested a total of approximately 75 positives, and we have identified 3 positives. So in the community, based on these newly diagnosed patients that I had a conversation with, they are experiencing, homelessness, and unemployment, and they're also having sex parties. So we were informed that here in South LA, there are a few sex parties where clients are gathering and are having sex with each other. So that's going to be an interesting dynamics, what happens with PrEP, because we're looking at about 4 or 5 months into the pandemic. So the afterwards effect, I think it's going to be very interesting. What type of numbers are we going to be seeing? Are we going to see newly HIV diagnoses? So that's going to be very interesting later on to see what happens.
Are you seeing people reaching out? Is there a change in people's coming to the clinic, wanting to get services, or has it stayed pretty consistent?
It had definitely slowed down. We had never stopped providing services at Oasis. We have had very few patients, I would say since March, maybe 6 patients seeking PrEP. And when we discuss PrEP here in South LA, I want to make sure that we cannot talk about PrEP and testing the way we talk about in West LA. Here in South LA, we have to focus on education. We were just getting comfortable with the community talking about Truvada. And now you're telling me there's another pill. So we got to be very careful how we introduce prevention services to the community, to the Black and the Latino community. And to me, it has to be more, health educators have been eliminated from the school-based setting. And that has to be brought back, because it's only the community workers that are in the community. I can't speak for the community, I can just speak for my experiences. But we lack any information. You can't just tell me to take a pill and it's gonna stop me from becoming HIV positive. Have to give me more information. Maybe a kid from West LA would read the information, but not in South LA, maybe not in East LA. So those are the main focus that I think we have to pay attention. You outreach according to the community you outreach into. You know, in the Latino community, we identified one positive last month, and Latino, and there's 5 families living in one household. So that's challenging, and that's what we deal with. And one person identified COVID positive, and what are they gonna do? Everyone leave the house? It's undocumented. So the situations and the access we lack in here in South LA.
Mr. Forbes, you're bringing up some very important points as to, like, when you were comparing between West LA or South LA and East LA. And I think you got some of the upstream factors of homelessness or crowded housing that you know, possibly increasing access to health education, health educators in particular, right, could maybe you know, mitigate some of those upstream causes. I'd like to also talk about the telehealth that was brought up. Across the panel, what have you been hearing about this shift to telehealth? Are there privacy concerns? Has there been more or less, you know, disparities that are associated with this kind of shift?
So I practice at UCLA Care, which I think is a very different setting, as it's in West LA, to what probably John is describing. However, we've had also just really severe decreases in our census of patients coming to the clinic since the pandemic started. And I mean, we're lucky enough to be part of this big health system that was able to nimbly provide us with telehealth services and try to help us roll these out to our patients. And I mean, for the young patients and even older, I guess, but they have been able to engage with the telehealth app and be able to keep their visits. It's never going to be the same, of course, as an inpatient visit. But I think it's a double-edged sword, right? Some patients actually really prefer it, especially if they live far away from us and they come to care. They may live in the Valley or they might live in Palm Springs, and they really enjoy having to just see us on their app if they're asymptomatic and everything is going on as routine. However, I think especially for our older population, that has been a bit more difficult, really having technical difficulties accessing the app, where we've actually had to just kind of convert the visit to a telephone call. But I mean, it serves its purpose, but it's never going to be as good as the app, and then it's never going to be in person.
What do you, Mr. Forbes, have you guys been using telehealth, and are your experiences similar or different? You're muted. If you could unmute yourself. Perfect.
Yes, we are currently at Oasis. Dr. Jordan and additional medical providers, they kind of looked at the patients and see the patients that really need to come into the clinic and patients that can do telehealth. And actually the older patients kind of like it because they never experienced this since being with Dr. Jordan since late 80s, 90s, and now. So their response is, I never got a phone call from you till now. So, and then the young, like I say, it depends on the patient. So that at Oasis, we kind of looked at each patient and said, this is how we're going to go about treatment as far as them coming in for their labs. But yes, a lot of patients, it's a double sword.
So, I would love to bring Ms. Aziza and Solange into the, in the conversation, and thinking about, the evolving and sometimes inconsistent messaging around COVID-19 impacted patients and caretakers' attitudes, in particular with prevention and testing. What are some of the things that you guys have heard in terms of the messaging that people are receiving and the impact that it's had on, for example, them being receptive to more care or more contact, right?
So I'll go first. Previously mentioned that a good amount of my work has been in the faith community relative to research pieces. And there have been some very interesting movements across the faith community at large, and I'm speaking about in the African American community as well as in other communities. And so there have been some, it's a community that often will follow the direction of a pastor. And so we've had situations where pastors have felt that they wanted to lead by way of faith and sort of speaking those things that are not as if they were, which have biblical underpinnings. And so have decided to, at times, open up church and trust. And then there have been catastrophic consequences as a result. But then there have been plenty of other in the faith community who have said, we are going to absolutely follow the direction of the CDC and the government entities and abide by those mitigation strategies and close down and learn how to utilize these platforms like Zoom and others and Facebook Live and begin to have worship service in that way, which has been very interesting. And I think, again, it's sort of finding the silver lining in something that's horrible. It has certainly increased the capacity of people to know how to utilize these platforms for things like, of course, faith, which is the backdrop, but also health literacy, because I know that certainly speaking with some pastors, they take out a certain part of the time within the worship experience to share information about the most recent information about COVID-19 and mitigation strategies and the like. But again, health literacy, that has been a platform now. Those kinds of platforms, again, Zoom and others, in order to keep people safe and to try to get folk to learn how to live and make it through. We are communities that live in primarily, and we have people who are returning from prison, people who are returning from coming back from other kinds of recovery situations and back into their families, and that has been an issue of concern. And so I don't know, maybe we can talk about that a little later. I think how we welcome people back is very important, and how we make sure that they've been tested, that they don't bring what they contracted in these forced congregate settings, particularly again, prison and in prison. I don't know that there is the combined. We were trying to find out what happens with inmates before they are released. Are they tested just almost upon point of relieving? When they return, if in fact they tested positive, is there a safety net for them as well as their families, so that they can be quarantined and not bring that back home into the homes and expand that, and they become a super a spreader. And so those are the kinds of things that our community is discussing.
Many of the things that you just brought up obviously connect to structural racism.
It does.
And so,
Absolutely.
yeah. And
No
so
doubt.
we'll definitely come back to this.
Okay.
But I want to give Solange an opportunity to also respond.
Yeah, and I think in addition to the points that Aziza brought up, I'd like to say something about more from the perspective of immigrants. I am Hispanic, and so most of the calls that I've conducted, 98% of the calls have been with immigrants communities. So it's not only the inconsistent messaging about COVID-19, but it's also the anti-immigrant context in which we are that makes them fearful to even talk to me or seek medical attention or get access to any of the social services that we have. So that messaging is prevalent, is pervasive, and it's in everyone's minds, including myself, as I am an immigrant myself. So I understand when I talk to some of them, and they express even the concerns, and they ask me, if I don't go to the hospital, can I take care of myself here at home? And I know that that individual needs to get to the hospital because he's experiencing symptoms, and it's just devastating. And so what I have to do in that situation is try to talk to them with as much as empathy and use all of the training that I've been receiving to try to convince and motivate the person to seek medical attention, and also tell them that from the contact tracing perspective, none of the services that we have are or will be perceived as a public charge, because that's one of the main fears, and also really seek medical attention. So that's on one side. It's the anti-immigrant sentiment that is so prevalent and pervasive. The other component is the lack of access. I mean, not all immigrants have access to the same programs and resources. And that is unfortunate, because in California, at least, or actually nationally, a great number of people who are getting infected are immigrants. And so it's unfortunate that the people who are getting sick the most are the ones who are not getting access to the programs. And so that is another barrier. And lastly, the third is the stigma associated. And this is connected to your first and this question about a lot of now Hispanics, now it's now out that a large number of Hispanics are getting sick. And so now it's like associated COVID-19 with being Hispanic. And so how people are getting less and less motivated, and actually more the reasons are less to get a test, and the reasons for not to get tested are higher, because there's the stigma, there's also the economic barriers, or the economic or financial, the impact that a positive result may have on them. And so all of these are challenges that we're facing and that we have to work on to overcome them.
Solange, and I just want to say something. If I look at Spanish news and Spanish and English news, and it's totally different. The information the information from the Spanish channel and the English channel. So that's another huge barrier. The information provided to the community from the news.
Well, also information, not only news, but even I'm a trainer, and even from the training perspective, and one of the greatest needs is information in Spanish, in coherently, information on COVID-19 in Spanish. And for some reason, we have not been able to educate or develop the same materials as we have been developed in English for the community that needs it the most, the Hispanic community. So it's a reality that we do not have enough information about COVID-19, on how to prevent transmission, on what is COVID-19, even right there. So what is it? Who is at a highest risk? that information hasn't been developed in Spanish at the same amount as it's being developed in English. So that's another barrier.
And it seems as if, there's, because you're in San Francisco, right? And so the epidemic and the racial disparities look different, up north than they do, for example, here, or, in other parts of the country. But the structural issues, whether it was on access to care, issues of immigration, or as Ms. Aziza is bringing up, issues of over incarceration and criminalization, right? And those needs, those have, those are the foundation through which now what you guys are discussing is made even more complicated. And there is either the lack of messaging or inconsistent messaging that's kind of riddled, through that. If we were to move towards thinking about some of the possible solutions, because one of the objectives here of the webinar is to try to give our attendees some possible ways that we can address this this kind of unjust and very complicated and sophisticated, right, set of contexts that we're in. If we could go across and across the panelists and think about some of these solutions, what do you think would be some of the strategies, for example, to increase testing to COVID-19 or HIV testing? And I'd love to hear it both from the the provider perspective as well as from the community.
For the testing, I would say that we have to, well, first work on the stigma that is now associated with a positive test result. And so the messaging on that and the destigmatize what a positive COVID-19 positive is. And just to say, not that only this is a disease of Hispanics, this could affect anyone. And then the second one is to something that San Francisco has done that has worked well is these pop-up sites that instead of having people go to the testing site, have the testing site go to them. And so establish testing in the community and have people that are part of the community running those testing sites. And so instead of having people who are from the community and can encourage people to get tested.
At Charles Drew University of Medicine and Science, CNN just did a piece on us, I believe this past Saturday, because we have cars wrapped around the university because Drew was removing every possible barrier and heightening all of the facilitators to testing. And so that has to be addressed. Making people go on their computers to make appointments. Everybody doesn't have a computer and everybody's not and can't negotiate the computer to do that. Most people work through the week from Monday to Friday. Drew was open on the weekends and on holidays. And so, and coupled with the fact that Drew was doing some follow-ups with people. Now, I'm not talking about contact tracing. I want to talk about that a little bit later necessarily, although that we might be going into that. But I think that, again, all of the barriers had been removed. And that was the result of, again, a community and academics coming together to sit and talk. And then for Dr. Young, who was actually going into the community, asking people, why have you not had the testing? And hearing from them, and then being responsive to what they say keeps them from coming. It's very simple. Ask the people what they need. Nothing about us without us. It's just common sense.
Mm-hmm. I think that nothing about us without us is very important. Mm-hmm.
Yeah. To kind of, Aziza, as you know, during the time that we had testing here, which is coming to an end, sunset on Friday in South LA, we conducted outreach to mostly each and every single car on a daily basis. Give them
That's marvelous. I had no idea. That's wonderful.
Yes.
Wow,
yes.
what an opportunity.
Yes, what an opportunity. So we would go around and walk around the whole university for each and every single car,
Wow.
giving them a pump card, HIV testing, pet prep. After you finish, you can just come to Oasis. And most of the clients that we interacted with were coming from the Valley and South
Yeah.
LA. So yes, they were driving
Um,
away. So I hate to see that
yeah.
gone.
Yeah.
Um,
About the interconnections, the churches, I reached out and we got so many wonderful kinds of ways to support the testing site. And one of them was that we had some folks sat down to work on the site. And one of the workers, by name, Miss Edwina Fisher, she called me that evening and I asked her, I said, let me know how it went. She said, you know, she calls me First Lady because they still give me that honor. That's very sweet. My husband's been gone for a while. But she said, First Lady, there were 5 carloads of people in from Lancaster and a carload of folks driving in from Palmdale. I don't know what the situation is that they had to drive in so far, but the word got out because people, you know, each one reach one. And so folk were letting them know you can come even if you don't have an appointment for whatever reason, you can all come. And so there was just that, all come. It's a safe place to come. And that's what folk want. Folk want to know, number one, am I going to be safe? Number two, are you going to help me? And that it's a simple, it drills down to that with research and everything else.
I wonder how much of the Lancaster context also fits into the ways that they are fortunately a sister medical desert, right? You know, around what's happening, but then also the very importance of the way that the testing site in South LA at Drew has anchored itself, and is building, you know, those relationships, you know, of trust, which is, you know, obviously very solution oriented. And Mrs. Ziza, you were mentioning wanting to talk more about contact tracing.
Yeah, I do. I think, again, nothing formed without me and talking to the people. Listen, upon release of slavery, we know when we take a look at some books that folk have written, we see that there are parenting patterns that we have carried into present day. And one of them, because parents had to parent for survival. And so one of the sort of like the phrases that we use in the Black community is, don't talk about what goes on in this house. Don't you talk to anybody about what goes on in this house. And let me listen, upon release of slavery, there were never workshops, parenting workshops on how to act post-slavery. Number one, a whole lot of it didn't go away, but there was nothing like that. So a lot of the parenting carryovers, a lot of the same kinds of messaging that was a part of our survival has stayed within families. And so we come from a community that, look, whatever happens here, if there was a party, whatever happens in this house stays inside, and don't give out any information. That's just how we're trained from childhood up. So we just don't, we might tell you everything, but we still feel bound by codes of survival not to give information away. The wonderful Dr. Robert Garcia, who just passed away in April, a civil rights attorney. Robert Garcia, at a conference that Loretta Jones and I were a part of making sure happened for in the Torrance area that we promoted. At that precision medicine conference, Dr. Garcia spoke about how the 23andMe and sort of like that group were giving information to what is it, Homeland Security, and they were being able to trace people that they were looking for, they thought were criminals, from the information that came from the 23andMe and those platforms. And so nobody, they didn't tell people that would happen. Nobody thought that would happen, and they were promoted as just a way to find out your family, go find your loved one. But others were looking for those loved ones as well. So listen, it's these kinds of little aggressions, and that's pretty macro, that ain't even micro. These kinds of aggressions that sort of punch us and tell us, look, we never know what folk are going to do with our information, and so that's the problem. That is a problem. We need to be able to trust government, but government has got to stop doing that.
I'd like to, I don't know how many Latinos we have in the training, but I know a lot of Latinos documented that would rather go to Mexico and get treatment. They get treatment here in the US. Even though they document it, they prefer to go because they trust more medical providers in TJ or Mexico than they do in the US. It's you hear it all the time. Well, I do, my personal opinion. It's here I have to go through this, and he never prescribed me or gives me what I want or what I've been given that works. So a lot of people do tend to go south of the border to seek medical care. I'm sure I would like to see the response from the audience who might know someone they do go to Mexico to seek medical care.
So I'm actually from Tijuana, and I trained as a doctor in Tijuana, so I can definitely relate to that perspective.
Yeah.
And I mean, there's a large population in Southern California that does access their medical care because you can see a doctor from anywhere from $3 to $10 for a visit. If you're not insured and you can actually cross the border, it's a great solution, right? For our people who just don't have documents, that of course is not a solution. And at least with COVID right now, it's gotten better, but the hospitals in both Tijuana and Mexicali were just overburdened. So that phenomenon, and it's really difficult to cross over the border. But I know that, I mean, at UCLA and at our other community hospitals, DHS run like LAC, USC, or all of you, or Harbor, I mean, our Latino population is really disproportionately affected and disproportionately admitted to these hospitals. It's quite severe. To me, really, this is a structural problem. It's a systematic problem that we all try to work as individuals and try to help people on the ground, but it's really way above us, in my opinion. And in the reality that we're having 2,000 to 3,000 cases counted a day in LA County, that probably means that we have 4,000 or 5,000 cases at least a day in LA County. And we're reopening. I go out in West LA and I see bars, restaurants, they're fully open. People are close to each other. It's just, people seem to have forgotten that there are people dying every day and just seem to not be caring anymore for their economic benefit. So really, to me, the solution is we need to go back into lockdown. We need to really do it right, not just goal of flattening the curve, which is semi what we did. We really need to abolish the curve like Italy, like Spain, like the European countries did, because they're really direct comparisons to us, and they were able to do it and we weren't. So the only way to stop it is not with this patchwork framework that we're trying to do of, well, you can go out, but wear a mask. There's still the cases, and our most vulnerable, our Latino population, who is the people working at all these places, working in the factories, working in the restaurants, they're the guinea pigs getting infected, and it's just not right.
I'd like to stop this conversation right now, even though I don't want to, because I think we got into very important parts of identifying the kind of larger places of which the issue needs to be solved, right? So that it doesn't have an impact for the communities that we care deeply about. But we have fantastic questions that are here, and we'd like to go live with them. So let's see, I think it doesn't seem to indicate for me that there are any open questions, but I think Dr. Harawa is going to take over the Q&A. So
yeah, we have a lot of great questions, so we'll get to as many as we can. The first one I think could go to Solange. She's asking about whether contact tracers are providing resources for community members that might have barriers to some of the barriers that you talked about.
Yes, and I could speak about San Francisco County. However, I am cognizant that the social services that are available differ from county to county, and I'm in close touch with other counties such as Imperial County, which is one of the hardest hit counties in California. And so San Francisco is a very progressive city and is doing a very good job taking care of people who are close contacts and cases. So we offer all sorts of social services, from food, medicine, isolation and quarantine hotels, substance use, mental health. So there's a broad number of services. And my hope is that other counties are able to offer the same. San Francisco, even though cases are surging and we're experiencing right now a surge, given the city, in my view, opened up too early, still cases are not only lower in comparison to other counties. And I think that part of this, the contact tracing, it's one of the strategies. It can work only if it's just a call to tell people to stay at home for 14 days, given the structural barriers that we talked about. That would be impossible for 99% of the people who I talk to. So the social services part is key. And the other key part is testing, and having a testing that occurs fast enough in order for us to then reach out fast the contacts. So all of this is interlinked. And the more efficient all of these services work, the faster we are to get to people and prevent the spread.
Thank you. There was another quick question about contact tracing, and that is, are contact tracers mandated reporters?
Yeah, and so all the contact tracing work is voluntary. We cannot force to talk to anyone. And the approach that we do to our calls is more with empathy, with compassion. And I try, even when I conduct my calls, I try not to even use the word contact tracing, because that sounds policing, that sounds surveillance, and that's not the purpose of contact tracing. The purpose is to support people who have been in close contact with somebody with COVID-19 during 14 days. So we observe them to see if we develop symptoms or not. We connect them to testing twice during the 14 days. So we test them at the beginning and at the end. All of this it's voluntary. All the questions, if they don't feel that they're comfortable.
But if somebody does report something about abuse, abuse of a child or an elder, are you required to report that?
I would, so me as a contact tracer, I have access to other social workers, and I will, if the person would like to either say something, or if they tell me like, yes, I would like to connect with a social worker, then I do that. And I always run like situations like that. I would run it with the team lead. So I'm part of a larger group of contact tracers, and we are guided with a team lead. And so in a situation like this that I'm not entirely sure what is the right step, I would connect with the team lead and ask, does this warrant to somebody else to get involved in a situation like this? And then I'll get the guidance. Similar if it's a clinical question, if a contact wants to talk to a doctor or a nurse, then I will connect it.
So a different question for both John Forbes and David Goodman Mezza. How are you counseling patients right now? It's a very different question about what safer sex might mean in the age of COVID.
Oh.
Yes. Actually, wasn't the question I meant to go to, but go ahead.
Well, I think it's very delicate as far as getting the patient trust. Do you have multiple partners? making the patient feel very, very comfortable sharing with them. That's the beginning. Being educated to be able to inform the patient and give them the precise information as far as COVID-19 and safety precautions to take. And here at Oasis, we're doing that. We take checking temperatures as soon as the patient come in. The nurses talk to them about COVID-19. We have an isolation room. That's where we see most of the patient. We conduct all the testing. And the counseling has changed as far as educating the patient more on COVID-19 and the social distancing and try to prevent not being in a crowd of people.
So directly related to safer sex, I think it's really risk assessment. That's kind of how I go about it. The reality is that whoever you're having sex with, you're having sex with their network, and that's always been true for HIV, right? You're having sex with their sexual network, but for COVID now is you're having sex with their sexual network, but you're also having sex with their social network. So any persons that they've been in contact with the last 14 days. So if you're the higher number of people you see, the higher your risk of getting COVID. The more number of people they see, the higher risk of you getting COVID. And that's just the truth. So if you want to limit your risk, limit it to the least amount of people you can. If you don't care about your risk, then you'll be doing whatever you want and how as many partners you want to have. Sex is, it's really close contact. Transmission risk is, of course, going to be high. You just can't put a whole body condom on. So it's really limiting the number of people you're having contact with.
And Dr. Goodman, one of the questions that we have gotten asked a lot is it sexually transmitted? Can I get COVID sexually transmitted? So that's in the community right now. Since you can enter to my mucous membrane, can I get COVID sexually? So that's the new pattern we're seeing the question from clients.
As of yet, I've not heard a case report of sexual transmission through genital contact.
And I would like, even though as a contact tracer, we get frequently asked questions, and this is one of them. And so the approach how we answer this question is that we say that intimacy is part of being a human being. And so it's not to say no sex, no until we have a vaccine, because that's not going to be feasible for people. So what you do is you go the harm reduction approach. And so you talk about how COVID-19 spread, and similar to what Dr. Goodman says, to now, even though there's been COVID-19 seen in vaginal and semen, it's not known if it can be transmitted that way. So you leave the person with all the information. It's not the main route of transmission. That's not what it's seen. It hasn't been proven that it can't, but till now. So that's what I would do. I would say I would leave the person with all the information. It's riskier if you have a larger number of partners. Well, you also talk about, you normalize it and you say that intimacy is part of being a human being.
Thank you. One more question related to the patients that you see, David. There's concern expressed about supply chains for antiretroviral medications, and that some patients may be concerned about that. Are you giving people longer courses of medications for their refills, and how do you address any concerns about supply?
Yeah, so that since the beginning, I think my patients were on top of COVID from late February, early March, and just asking me, hey, instead of getting monthly refills, can I get 3 monthly refills? And we've pretty much converted all of them. Before, it was usually a challenge that insurance companies wouldn't cover 90-day refills, but in the times of COVID, they actually have. So that's really been beneficial to at least my patients. I really haven't come up with a challenge of concern with supply chains. specifically. I think just patients want to feel safe that they have a 90-day supply if they can't get to the pharmacy, if there's another lockdown, right?
So, Dr. Bunny, I'm going to ask a couple questions that came up about conspiracies, and then I'll let you choose if there's other ones you want to ask, because we have quite a few. But one person asked, how do we address all of these conspiracy theories that we're hearing from the community? I know a couple people have mentioned these, and I think anybody could address this, but maybe Mrs. Ziza, if you want to jump in first and talk about, how do you address it when people are talking about things that we know are probably not the case, but they're hearing from various parts of the media or even the White House.
Yeah, the White House. So, what I say and what I've heard others say is that you might be spot on. I come from a generation of the 60s where we saw conspiracy under every napkin and fork, and most of them were true. But the bottom line is whether it got concocted in some kind of political arena, whether it got concocted in a lab, whether it's an issue of ethnic cleansing, whatever it is, the fact of the matter still is that the virus itself is here. It's here. And we have to find out how to survive. We have to find out how to halt the spread. No matter no matter what the genesis is, we cannot shoot it. We cannot write a law against it. We cannot rally against it. We cannot do that with the virus. And so we have to treat it. We have to rely on science, the scientific community, for the ways in order to mitigate it and to to mitigate it as well as to cure ourselves. And that's it.
Thank you.
Because yeah.
Anybody else want to add to that? No. I think these are very hard, but so thank you. I'm glad I asked the right person. Somebody asked John to elaborate a little bit on the differences that you're seeing between Spanish and English media, and have there been any efforts that your group has made to reach out to Spanish media or other local community leaders around messaging?
No, we have not, Nina. As far as the Whittier, Pico Rivera area, we were in the process of having a meeting with council board, because currently there's only one agency in the whole entire East LA area that's providing HIV services. And right now, the Montebello opened a testing site yesterday. We're planning on targeting that particular area as far as bringing more people awareness. But here in South LA, what we see, we do see patients calling in for HIV testing, commercial sex workers, as far as with the district attorney. We have had an increase lately. We have appointments coming in this week and next week. So we're starting to see a pattern of more testing in the community.
Do you want to ask the last couple of questions, Beta?
Well, I think in the remaining 2 minutes, a question that came up in the chat that kind of connects to something that Mr. Forbes said earlier around health education. I would love to hear what the last thoughts from the panel on the role of public health educators, and community health workers in particular, being the role that they can play in educating the public, and maybe even getting ahead of some of the conspiracy theories or the damage that is done both through, the creation and the perpetration of them.
I'd like to answer that question because I'm happy to say that I know that for the entire state of California, the next big effort for COVID-19 is work hand by hand with community-based organizations. So there's an effort, and I've been working for the past 2 months with CBOs. And this effort is not necessarily to just have community members just have part of our efforts, but really have CBOs lead efforts. And one of the things that I've been hearing over and over and over again, especially from, again, Hispanic audience, is that Hispanics are totally capable of not only like participating, but leading these efforts. I hear from CBOs that, yes, I mean, Hispanics are sometimes brought into these programs, but it's just like to either be in, like, for instance, in pop-up events to hand sanitizers. And that's not the role that you want to have Hispanics do. You want to see community leading efforts. And this has to be intentional for either faculty, from UCLA, from UCSF, that if you really want to see a change, you have to bring them. It's not enough to also have them as part of a member here and there. They have to lead. By having CBOs and community members leading efforts, you're going to hear what the community really thinks, sees things, and that's the only way that you can address the mistrust, by having people that look like them, sound like them, think like them. That's the only way. And lastly, this is something that not only for COVID, but if you also are going to think about that a vaccine is going to change things. If a vaccine comes tomorrow with the mistrust levels, that wouldn't work, because a large proportion of the population will get a vaccine right now. And so I think that this effort, the mistrust, has to be taken seriously. And I applaud your effort of having this as the topic of today's discussion.
Real quick, Nana, I would just like to see if we can return to having sexual education in the LA County. I know when I went to school, that was the big one, when you can talk amongst your peers, you feel comfortable asking certain questions. And the LA County is one of the biggest county in probably the United States, and it's just not talked about. That's where, to me, that's where that's what we need to focus on, the high schools and trying to reach the youth. That's where the community outreach begins.
So thank you for that, and thank you for both of your comments. Unfortunately, we are actually at the time, so I'm going to, I guess, take sort of whatever chair's privilege and bring our discussion to a close. But I think this has really been a tremendous discussion, and really has highlighted the complexity of what we're talking about, but how interrelated the issues are, how interrelated the concerns that have existed for a long time around HIV are now being have now come to the fore around COVID, and in many ways affecting very much the same communities. So I really want to thank all of the panelists for the perspectives and the work that they're doing in this area. There's been a number of resources that have been shared in the chat that I would encourage people to look at. There's some other resources that we have that we will compile that will hopefully also address some of the questions that we were not able to get to. And we're going to compile those as well as the recording and make that available at our website, which is chips.ucla.edu. Any final words you want to say, Dr. Amani, before we wrap up?
No, I mean, I think so much of the work that was done between the academic and activist organizing community partnerships that have been in the history of HIV/AIDS, all that work, 100 times more, is what has been needed, and is definitely what's needed as we move forward. And it's really encouraging to see that people are bringing that thoughtfulness from the past into the moment and want to take it into the future. So thank you, everyone, and to be continued.
Yeah, thank you all. And I'm going to try to see what I think, can we leave the Q&A open, as if we can answer some of these questions in the Q&A, maybe we will for the next few minutes or so. But thank you again, everyone. Thank you, everyone, once again for participating. We hope you have a great rest of your day and that you stay safe and share this information with your networks.